So it's recording. Good evening, everyone. So I would like to welcome everyone for this basic module, basic module one from Critical Care Forum. I am Dr. Vishwapal, Critical Care Forum member, and today's topic is on pain, agitation, and delirium in intensive care unit. So, as we all know, critical care area is something where we could see the patient suffering from pain, which is actually an uncontrollable pain, and mostly the patient might require intubation. Even the patient is even if the patient is conscious, so to tolerate all those kind of pain and agitation, uh, it's actually very much necessary for us to know the medications and non-pharmacological and pharmacological treatment from our side as a clinical pharmacist. So I would like to introduce Dr. Sufia, um, who's going to take over the session. Dr. Sufia has a commendable background as a clinical pharmacist, working in critical care since 2021 at Continental Hospital in Hyderabad. Her expertise in emergency drug dilution protocols, dose adjustments for various type of dialysis, and antimicrobial stewardship highlights her proficiency in managing complex clinical scenarios. Graduating from Deccan School of Pharmacy in Hyderabad likely provided her with a strong foundation in pharmaceutical sciences and clinical practice. A focus on critical care suggests a commitment to ensuring optimal patient outcome in challenging medical situations. So I will welcome you, Dr. Sophia, and the session is yours.
Thank you so much, Vishwa, for the introduction. Hi, and a very good evening to one and all. I am Dr. Sufia Iram Irshad, working as a clinical pharmacist at Continental Hospitals in Hyderabad. And today I'm going to present my session, my basic module session on pain, agitation, and delirium in the intensive care unit. Pain, agitation, and delirium, the terminologies will be very common for the clinical pharmacists who are working in the critical care unit. These are the commonly seen factors in the critical care unit, and being a clinical pharmacist, we are going to see how are we going to deal with all these three parameters that we see in the ICU. So disclosure, I do not have any financial relationships with any commercial interests. Learning objectives. So what are we going to learn from the presentation today? The description and incidence of pain, agitation, and delirium, that is PAD, in the intensive care unit. Evaluate patients in the ICU for pain, agitation, and delirium is using a validated screening tool. Identify the non-pharmacological approaches for PAD in the ICU and discuss relevant pharmacological considerations as well. So let's begin with pain. What is pain? If we have to tell about pain, if you have to describe about pain in a simple word, we would say it as an unpleasant feeling, unpleasant emotional feeling, or a physical feeling. But if we have to define pain, how would we define pain? So the International Association for the Study of Pain has defined, that is IASP, has defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. And in a critical care setting where we see patients who are mechanically ventilated, and over 30 to 50% develop delirium, and they develop delirium, in a critical care setting, we see patients who are mechanically ventilated, and 30 to 50% they develop delirium, which makes the assessment of pain difficult. I'm sure many clinical pharmacists will can correlate with this, as the assessment becomes difficult when we compare the patients who are in the critical care when compared to the patients who are in the normal wards or the normal OPD patients. If the patients in the ICU, the assessment for pain, the patients in the ICU becomes difficult when compared to the normal patients, and hence it requires some standardized and objective measurements. That is the scoring or the scaling tools. So the assessment of how do we assess the pain? SCCM, that is the Society of Critical Care Medicine guidelines, have currently recommended 2 validated behavioral pain scales that can be done in a repetitive and routine manner. One is the behavioral pain scale, and the other would be the critical care pain observation tool. The difference between both of them is that both can be used in the ICU setting, but the behavioral pain scale has a parameters which are limited towards the upper body or towards the upper limbs only. Whereas the CPOT, that is the critical care pain observation tool, that will let you know about the complete body, the tone movements of the patient as well. So let's move ahead with the behavioral pain scale. How do we assess the level of pain of a patient? So the different factors or the different parameters that we look into while seeing the behavioral, while scoring the patient for pain are through the BPS are facial expression, upper limbs, and compliance with ventilation. So as you can see the scores which are given on the right side, we depending on the condition or the description of these parameters, we score the patient, and based on that, we move ahead with the therapy or the management for the patient. The facial expression, if the patient seems to be quite relaxed, then we score the patient as 1. If the patient seems to be partly tightened, that is the eyebrows are lowering down, then we score the patient as 2. If the patient seems to be fully tightened, like the eyelids seem to be closing, then we score the patient as 3. And if the patient is grimacing, then we score the patient as 4. Next, coming to the upper limbs, if there is no movement at all, then we score the patient as 1. If it is partly bent, then we score the patient as 2. If there is a fully bent with finger flexion, then we score the patient as 3. Whereas if it is permanently retracted, then we score the patient as 4. No movement, as in the patient is quite calm and relaxed, whereas permanently retracted is the patient means that the patient is in pain. Coming to compliance with ventilation, if the patient is tolerating the movements, then again we score the patient as 1. If the patient is coughing but still tolerating ventilation most of the time, then we give it as 2. If the patient is fighting with the ventilator, then we score the patient as 3. Whereas if the patient is unable to control the ventilation, then we score the patient as 4. So depending on the scoring of this, we move ahead with the treatment of the pain for patients in the ICU. Next is the critical care pain observation tool, that is the CPOT. As we have already discussed, that the CPOT involves the complete body. So here again, we see the facial expressions, the body movements, the muscle tension, and then with the compliance with the ventilator for the intubated patients or the vocalization for the extubated patients. So here again, the facial expression, as we can see, if the patient seems to be relaxed and neutral, the score would be 0. If the patient seems to be tense, that is, there is presence of frowning, brow lowering, or orbit tightening, then the score would be 1. And if all the above facial movements along with the eyelids being tightly closed, then we score the patient as 2. For the body movements, does not move at all, that means, as I've said, that the patient is in a relaxed state, but that does not necessarily mean that the patient does not have pain at all. We give the scoring as 0. If there is slow cautious movements or touching or rubbing at the pain site, then we give the score as 1. If the patient is trying to pull the tube out or is trying to sit up, basically in a little irritable state, or moving the limbs and thrashing, not following the commands, striking at staff, and trying to climb out of the bed, which is all out of pain, then we rate the patient as restless, that is number 2. And then coming to the muscle tension, we might have seen that we see the consultant being doing the different kind of movements with the patients to see what level of pain they are in. So if there is no resistance to the passive movements, that means the patient is relaxed and there is a score of 0. If there is resistance to passive movements, then the patient is tensed and rigid, and we give the scoring as 1. And if there is a strong resistance to passive movements, that is, they are incapable of completing them, they don't have the ability to complete them out of their pain, then the patient is very tensed or rigid, and we score the patient as 2. Now, coming to the ventilated patients, the intubated patients, we see the compliance with the ventilator. Again, if the patient is tolerating the ventilator, we give it as 0. Coughing, but again tolerating, 1. And if the patient is fighting the ventilator, then we give it as 0. Whereas for the extubated patients, we see the vocalization, how they are talking. If they are talking in a normal tone, then we score as 0. If they are sighing or moaning, then we give it as 1. If they are crying out or sobbing out of pain, then we score the patient as 0. So the total range, when it comes from 0 to 8, then we move ahead with the therapy, with the level of pain that we need to manage. So before going ahead with the pharmacological approach, let's see what would be the non-pharmacological approaches in pain management. Yes, we do have patients with severe pain, suffering from severe pain, agitation, or delirium in the ICU. But being the clinical pharmacist, it is our responsibility to also have knowledge of what could be the non-pharmacological approaches in pain management, or in any kind of management, any kind of therapies as well, before moving ahead with the medication part. So non-pharmacological approach means management of pain without the medications. So let's go ahead with some examples. The first, a few of the examples would be comfort therapy, physical and occupational therapy, psychosocial therapy or counseling, and neurostimulation. Coming to the first, moving towards comfort therapy. If there is a companionship, that is the presence of a family member or friend near the patient, meeting them often. Yes, in ICU, it becomes difficult to meet the patient, but whenever they're able to meet, then this might help them relieve with their pain. Exercise, make the patient exercise if they are in a condition to do so. Heat or cold application might also help in relieving the pain. Massage therapy, meditation, presence of some music or art around them will also help them to relieve the pain. Or a proper positioning will also, if there is some kind of physical pain that the patient is suffering from, that is post-surgical pain, then the correct positioning might also help to relieve them from pain. Physical and occupational therapy. Aqua therapy, that is some therapy or a massage with water. Tone and strengthening and desensitization are some of the ways where we can help the patient relieve their pain. Psychosocial therapy or counseling. Individual counseling, if there is some kind of psychological condition that the patient is facing, and because of which they are in pain, then an individual counseling or a family counseling or a group counseling might help them recover from their pain. Different kind of neurostimulation techniques might also help them. Some examples would be TENS, that is transcutaneous electrical nerve stimulation, acupuncture, and acupressure. These are also some of the ways, some of the non-pharmacological techniques that we can use to help the patient relieve from their pain. And it is always suggested from the guidelines that we should always assess the level of pain and then go ahead with the treatment, be it pain, agitation, or even delirium. Coming to the pharmacological approaches, in a patient whose pain is inadequately controlled in the ICU, IV opioids are considered as the first-line treatment for the non-neuropathic pain. General mechanism of action, if we say in simple terms, it would be saying that it would bind to the mu opioid receptors in the central nervous system. Whereas if we have to see a slightly deeper understanding of the pharmacology, then we can say that the opioids act both presynaptically and postsynaptically to produce an analgesic effect. Presynaptically, the opioids block the calcium channels, which contribute to the nociception. Whereas postsynaptically, the opioids open the potassium channels that would help them to generate the nociceptive transmission. Hence, the mu, kappa, and the delta opioid receptors mediate analgesia spinally and supraspinal. So the commonly used intravenous opioids in the ICU are fentanyl, morphine, hydromorphone, remifentanil, and methadone. The most common ones that we get to see on a daily basis would be fentanyl. The onset of action. Let us see some of the parameters of all these drugs. Fentanyl uh, is the most common drug, as I've already mentioned. It is the most common drug that we see in the ICU setting for the management of pain, which has the quickest onset of action, that is 1 to 2 minutes when compared to the other drugs. The dose of fentanyl is the loading dose would be 0.35 to 0.5 mcg per kg, and then followed by the maintenance dose, that is 12.5 to 25 mcg per hour. Some of the adverse effects. Adverse effects, now if we go to if we see for the drugs, it would mostly be similar for all the drugs, for all the analgesics or sedatives that we go ahead. So the adverse effects, some of the side effects of fentanyl would be respiratory depression, bradycardia, hypotension, CNS depression, and constipation. So when we give medications to relieve the pain of the patients, we should always have a very keen and strict monitoring on the effects that these medications have on the patient, because these medications, in one way where they help in relieving the pain, the other way they also have severe adverse effects on the patients, which can be life-threatening for them. So whenever we give medications, we should always be very careful and have a keen monitoring on the effects of the drug, on the effects that the drug is producing on the patient, because these are mostly continuous infusions that we give. So some of the precautions that we need to look out when we give fentanyl would be hepatic failure, high volume of distribution, high lipophilicity, and unpredictable clearance due to prolonged infusion. As I've already said, that these are all continuous prolonged infusions. So we always need to we always need to have a keen monitoring on the effects of these drugs. We cannot underdose the patient, but we cannot overdose the patient as well. Second drug would be morphine, which is the onset of which is 5 to 10 minutes. The dose would be 1 to 2 mg per hour. Adverse effects are histamine release, again can cause same hypertension, bradycardia, respiratory depression, CNS depression, constipation. And the precautions would be hepatic failure, active metabolite accumulates in the renal failure. Next is hydromorphone, which has an onset of action of 5 to 15 minutes. The dose would be 0.25 to 0.5 mg per hour. And the adverse effects are again CNS alterations, such as abnormal dreams, aggressive behavior, and altered thinking, respiratory depression, hypotension, and constipation again. And the precautions that we need to look out is for the hepatic failure. So as we can see that there are many drugs over here that have that need to be looked down for the hepatic failure. Whenever we are giving these drugs to the patients, being clinical pharmacists, it's our responsibility to also have a look at the liver abnormalities or the hepatic values in order to rule out if the patient is having any adverse effects. Methadone, a quite high drug where the onset of action would be 1 to 3 days, and the dose would be decided by the consultant, ICU consultant. Adverse effects are that dose-dependent QTC prolongation, and it has an altered mental status, respiratory depression, confusion, dizziness, arrhythmias, and constipation. Precautions are that it has a longer half-life and hepatic and renal failure with delay in clearance. Remifentanil, the onset of action is again 1 to 3 minutes next to fentanyl. The loading dose would be 1.5 mcg per kg. And the continuous infusion would be or the maintenance dose would be for 0.5 to 15 mcg per kg per hour. Again, we can see that the adverse effects would be respiratory depression, bradycardia, etc. So it is our responsibility, being the clinical pharmacist, that whenever we give these drugs, whenever these drugs are going on to the patient, we should always monitor we should always look out for which would be the best drug for the patient, keeping in mind the adverse effects. And you should always look at the appropriate dose that should go to the patients. And again, as I said, because these are prolonged infusions, so we need to look out for the effects that these drugs are having on patients in order to save the patients from further complications. Okay, so moving ahead, PADIS guidelines. What is PADIS guidelines? The full form of PADIS is pain, agitation, delirium, immobility, and sleep disruption. So these guidelines have been developed by the SCCM, that is the Society of Critical Care Medicine, which provides a roadmap for developing integrated evidence-based and patient-centered protocols. These guidelines are revised every 5 years, or whenever the new evidence is made available, then these guidelines will be revised. So the latest guidelines are of 2018, which is an updated expansion of the 2013 guidelines. So according to the PADIS guidelines, the first line treatment, as we have already seen, that the first line treatment for pain would always be opioids. But if the patient is at risk for opioid side effects, then we see for other alternatives, that is for nociceptive pain or neuropathic pain. For neuropathic pain, we go ahead with the neuropathic agents. But if there is nociceptive pain, there is chances for multinodal analgesia with acetaminophen, mifopam, low-dose ketamine, ketorolac. These are an alternatives where we get to see lesser side effects. So let's see a few of the neuropathic drugs that we give when the patient is suffering from neuropathic pain. These are common ones. We tend to see it in the normal settings as well, normal IPD settings as well, not only the ICU. First one would be gabapentin. The dose would be 300 to 600 mg per day, divided 2 or 3 times in the day. And the maximum dose would be 3600 mg per day, but it should be in 3 divided doses. Adverse effects would be seen as depression, delirium, paresthesias, that is numbing or burning sensation, and asthenia, that is generalized physical weakness or lack of energy. And these can be severe as well if given for a prolonged time. Next is carbamazepine. The dose is 50 to 100 mg twice daily, and the maximum dose is 1200 mg per day. Adverse effects, somnolence, that is excessive sleepiness, severe skin reactions such as Stevens-Johnson syndrome, and other ones would be pancytopenia and syndrome of inappropriate in antidiuretic hormone, that is SIADH. Next commonly seen drug is pregabalin, that is 50 mg 3 times in a day is a normal dose, and the maximum dose would be 100 mg 3 times in a day. The side effects would be peripheral edema, dizziness, drowsiness, headache, and fatigue, visual field loss, and blurred vision as well. Let's move ahead for some other drugs that we have just discussed for the nociceptive pain. Some of the examples would be local and regional anesthesia such as bupivacaine. The PADIS guidelines does not recommend the use of intravenous lidocaine as an adjunctive to opioid therapy for the pain management. Another adjunctive to opioid analgesics would be acetaminophen, one of the most common painkiller that we see in a day-to-day life. That is a good alternative to opioid in order to decrease the pain intensity and to decrease the opioid consumption as well. So a maximum of 4 grams per day of acetaminophen can be taken. Others would be intravenous or oral NSAIDs such as ibuprofen or ketorolac. And ketamine, the PADIS guidelines suggest for the post-surgical patients who are admitted to the ICU, the PADIS guidelines suggest the use of low-dose ketamine, that is 1 to 2 mcg per kg per hour, as an adjunctive to opioid therapy. These are alternatives when we seek to reduce the consumption of opioid and along with that to decrease the pain intensity. These are alternatives to opioid analgesics. Analgosedation. Okay, so the name itself suggests says, what could it be? So this is a method of sedation which advocates the use of opiate medications before an hypnotic or an anxiolytic medication is prescribed to provide comfort to the patients in the ICU. Yeah. The PADIS guidelines recommends analgosedation, that is, either the analgesia is used before a sedative to reach the sedative goal, because we know that analgesics can also cause sedation, or analgesia-based sedation, that is, an opioid is used instead of a sedative to reach the sedative goal. So this is one of the biggest recommendation by the PADIS guidelines, that is, to prevent sedatives being given, we can use analgesics also to reach the sedative goal. Providing pain relief early in the ICU stay may decrease the agitation that is associated with the pain and general discomfort, while minimizing the use of alternative medications commonly used for agitation as well. Example, benzodiazepines. So the method of agitation, analgosedation is a positive step in decreasing the untoward adverse effects, that is the unwanted adverse effects of the benzodiazepines class of sedatives. There's a potential for high cumulative doses of opioids with, again, when we say that if we are giving opioid analgesics instead of the sedatives, we again have to keep a strict monitoring for the use of opioids, because there can be a potential of high cumulative doses of opioids with the analgesedation method, necessitating daily monitoring of their adverse effects. Again, as I've already said, that if we are using the analgesedation method, then we are using the opioids instead of the sedatives. But again, we know that opiates have a lot of side effects, adverse effects, and which necessitates the daily monitoring and a strict monitoring for their adverse effects, such as respiratory depression, altered mental status, and GI slowing, gastrointestinal slowing. Now, moving ahead with agitation. What is agitation? In simple words, we say that it is an irritable feeling that the patients usually experience in ICU. So agitation and anxiety occur frequently in critically ill patients and are associated with adverse clinical outcomes. Sedatives are commonly administered to ICU patients to treat the agitation and its negative consequences. So most of the common causes for agitation in the ICU include pain, delirium, hypoxia, hypoglycemia, dehydration, and drug or alcohol withdrawal. These are some of the common causes of agitation in the ICU. So the assessment scale for agitation. The Richmond Agitation Sedation Scale, that is the RASS scale or the RASS score, is an instrument that is designed to assess the level of alertness and the agitated behavior in the critically ill patients. The scale has a score is a 10-point scale, which is ranging from -5 to +4. Let's see how do we scale the patient, how do we score or scale the patient based on this assessment scale. Okay, so this is how the scale looks like, where 0 means that the patient is quite alert and calm. That means the patient is spontaneously paying attention to the caregiver. Going above, we see that the +1 to 4 scales, may we see the agitated behavior of the patient, whereas going below the 0, that is from -1 to -5, we see how deeply the patient is sedated. So if the patient is anxious, but the movements are not aggressive or vigorous, then the patient is restless, and the score is given as +1. If there are frequent non-purposeful movements and the patient fights ventilator, then the patient is agitated, and we score the patient as +2. If the patient tends to pulls or removes out the tubes or catheters and seems to be very aggressive, then the patient is very agitated, and we score the patient as +3. And if the patient has become violent and he or she can be an immediate danger to the staff, then the patient is labeled as combative, and the score given to the patient is +4. Coming down towards the sedation, if the patient is not fully alert but has sustained awakening to the voice, uh, then for more than 10 seconds, then the patient is drowsy. -1 is the score that we give. If in case of light sedation, the patient briefly awakens with eye contact to voice, but less than 10 seconds, and the score given is -2. Moving ahead, movement or eye opening to the voice, but there is no eye contact, then there's moderate sedation, which is -3. If there is no response to voice, but there is movement or eye opening to any physical stimuli, then there is deep sedation, and score is -4. And in case there is no response to voice or the physical stimulation, then the patient is unarousable, and we score the patient as -5. So let's see the procedure. It is as to how to score the patient or scale the patient for their agitation. First, we need to observe the patient. If is the patient alert and calm? If yes, then we score the patient as 0. Does the patient have the behavior that is consistent with restlessness or agitation? Then we score the patient from +1 to +4, as we have seen over here, from restlessness to being combative. Then if the patient is not alert, then how do we see the sedation? In a loud speaking voice, we need to state the patient's name and direct the patient to open the eyes and look at the speaker or the doctor or the consultant, whoever is saying this to the patient. It can be repeated once again if required. And we can prompt the patient to continue looking at the speaker. If the patient has eye opening and eye contact, which is sustained for more than 10 seconds, then we score the patient as -1. If the patient has eye opening and eye contact, but this is not sustained for 10 seconds, that is less for 10 seconds, then we score the patient as -2. If the patient has any movement in response to voice, excluding the eye contact, then the score given is -3. If the patient does not respond to voice, but physical stimulate patient by shaking, then we need to physically move or stimulate the patient by shaking their shoulder and then rubbing the sternum. If there is no response to shaking the shoulder. If the patient has any movement to the physical stimulation, then we score the patient as -4. And moving ahead, if the patient has no response to voice or any physical stimuli, then we score the patient as -5. Some of the non-pharmacological approaches in agitation, the management of agitation, we usually tend to see that agitated patients are there in ICU, where we directly start with the pharmacological treatment, seeing that the patient is very agitated and can be harmful. But first, as we have already discussed, we always need to scale the patient, rate the patient's level of agitation, and based on that, we need to start with the therapy. But before that, if we can, we should always look out for non-pharmacological approaches as well, some of which would be nature-based sounds or music around the patient, which might make the patient relaxed and calm. Food reflexology, that is food massage, a soft food massage would help the patient as well. Or a healing touch from a family member or a friend would also be a good alternative for relaxing the patient. Or aromatherapy, that is good smell, good aroma around the patient, might also help the patient be in a relaxed and calm state. Moving ahead with the pharmacological approaches in the management of agitation, the SCCM provides the following statement, the PADIS guidelines, that is, we suggest using either propofol or dexmedetomidine over benzodiazepines for sedation in critically ill and mechanically ventilated adults and those after cardiac surgery. It states that benzodiazepines may be at a risk, maybe a risk factor for the development of delirium, which we would not want to have. So benzodiazepines are less preferred over propofol or dexmedetomidine because it is a major risk factor for the development of delirium in the ICU patients. So some of the drugs, medications that we use for agitation management would be propofol, which has a quick onset of action, which is 1 minute. The dose would be either 5 to 50 mcg per kg per minute or 0.3 to 3 mg per kg per hour. Adverse effects of these drugs would almost be the same, that is hypotension, respiratory depression, bradycardia. And precautions that we need to look out would be hypotension, again bradycardia, hepatic or renal failure, and pancreatitis. Dexmedetomidine is again one of the most common drugs that we tend to see in the critical care setting for agitated patients. Onset of action would be 5 to 10 minutes. The loading dose is 0.5 to 1 microgram per kg, and the maintenance dose would be 0.2 to 0.7 microgram per kg per hour. Adverse effects would be hypo or hypertension, bradycardia, pyrexia, that is increase in the temperature, and precautions would be a hepatic failure and symptomatic bradycardia. Lorazepam and midazolam, benzodiazepines. Lorazepam, the onset of action would be 5 to 20 minutes. Intermittent 1 to 4 mg IV every 4 to 6 hours is the dose. And adverse effects again are oversedation, as we have already discussed, propylene glycol toxicity. And delirium and renal failure are the precautions that we need to look out when if we have to administer the patient with lorazepam. And midazolam, 3 to 5 minutes is the onset of action. The dose is 0.02 to 0.1 mg per kg per hour. Oversedation again is the adverse effects, and hepatic failure or end-stage renal failure or dialysis and delirium are the precautions that need to be looked out for patients who are being treated with these medications in the agitated patients. Now, titration of sedation is in ICU. First of all, we have seen the non-pharmacological approaches that we see in order to heal the patients who are in pain or in sedation. Then we have seen the pharmacological approaches as well. So when we go ahead with the pharmacological treatment of the patient, it is also always necessary to titrate the medications, that is the sedatives or the analgesics, when the patients are in ICU, because we cannot keep the patients on prolonged medications because of their severe adverse effects, and which can be life-threatening for the patients as well. So what happens if we titrate the level of sedations in ICU? It decreases the time of the patient on mechanical ventilation. It decreases the ICU length of stay, and it decreases the rates of tracheostomy, which may all result in faster physical and cognitive rehabilitation time. The PADIS guidelines suggest using light sedation in critically ill and mechanically ventilated patients. And it states that patients should always receive sedation only if required. And sedatives should be titrated to allow patient responsiveness and awareness, as shown by patient's ability to purposefully respond to a combination of any three of the following actions on request: open eyes, maintain eye contact, squeeze hands, stick out tongue, and wiggle toes. This means that when we are titration of the sedation does not just mean that we have to slow down because of side effects only, but to also see how the patient is responding. Uh, sorry, how to see how the patient responses when the sedatives have been titrated or are being weaned off. So if any of the three parameters the patient is showing positively, then we can continue to titrate the medication. Three factors among the five would be open eyes, maintain eye contact, squeeze hands, stick out tongue, and wiggle toes. And that is movement of the toes. Acute withdrawal syndrome of long-term analgesia and sedation in the ICU. This is also one of the common things that we tend to see once the patients are shifted from ICU to the wards, or they are being weaned off from their analgesics or sedatives in the ICU. High doses of continuous infusion, sedation, and analgesia in the ICU would cause the withdrawal syndrome or the withdrawal symptoms. Risk of sedative or analgesia withdrawal as dose tapering begins. We see that the withdrawal symptoms or the syndrome begins as we start to wean off or titrate the analgesics or sedatives. So analgesics and sedatives, as we have already mentioned before, that the keen monitoring on the effects are very important, because these are important considerations in the long-term ICU patients. And longer-acting agents given orally or by feeding tube assist in the transition of long-term continuous infusions. Okay, moving ahead with delirium. So what is delirium? Delirium is an acute and fluctuating disturbance in consciousness resulting in the inability to receive, process, store, or recall information. In the ICU, the delirium may be present as three types. One would be hyperactive, that is the patient is agitated and restless. Hypoactive, that is the patient is flat affect. That the patient has flat affect. Apathy, that is lack of emotions, lethargic, and there's decreased responsiveness. Or it can be a mixed hyper and hypoactive states. So the most common ones that are seen in the ICU are mixed and hypoactive states of delirium. Large reviews around the world suggest that around 1/3 of all the ICU patients are delirious. Okay, so again, assessment of delirium or the screening tools for the delirium. The PADIS guidelines have recommended two screening tools for the assessment of delirium, that is confusion assessment method for the ICU or CAM ICU, or the other one is the intensive care delirium screening checklist, that is the ICDSC. So first of all, let's see how do we use the confusion assessment method for the ICU, that is the CAM ICU. If there is an acute change or fluctuating course of mental status, is there an acute change from the mental status baseline, or has the patient's mental status fluctuated during the past 24 hours? If this has not happened, then the patient can be rated as CAM ICU negative. That means there is no delirium present. If this has happened, if there is a change in the mental status of the patient, then we move ahead with the second step, that is inattention. We have to the ICU consultants can ask the question to the patient, as in, squeeze my hand when I say the letter A. Read the following sequence of letters: SAVEAHAART. Errors: no squeeze with A and squeeze on the other letters other than A. If the patient does not squeeze on A and squeezes on other letters than A, then that means that there are errors. If the scoring is between 0 to 2 for errors, then we say that there is no delirium. Patient might respond to 1 or 2 A's also. But if there are more than 2 errors, then we need to see the current altered. Then we need to see the current RASS level, because there is an altered level of consciousness. Patient is not fully conscious, but there is an altered level of consciousness, and we need to see the RASS level. If the RASS score is other than 0, then we say that the patient is CAM ICU positive or there is delirium present. But if the RASS score is 0, then we see for other factors such as disorganized thinking. And we do an activity with the patient such as hold up my finger, hold up these many fingers. We can ask the patient to hold up to 2 fingers and then do the same thing with the other hand. And we do not demonstrate it for the second time. And we can add 1 more finger also if the patient is unable to move both the arms. If there are errors in this more than once, then again the patient is we scale the patient as delirium present positive, and if there is a 0 to 1, then we say that that there is no delirium. If the patient is able to hold at least one hand and not the 2 hands, then we can say that the patient is having no delirium. But if it is more than that, then we say that the delirium is present. The intensive care delirium screening checklist, the ICDSC. We can see that there are 8 parameters over here. So once we while checking for all these parameters, we need to score each parameter. If there is if the patient is positive for each of the parameters, then we need to give 1 point for each parameter. And if the total score after the final assessment is more than 3, then we say that the delirium is present. So first of all, we see that if there is any altered level of consciousness, if the patient seems to have altered level of consciousness, then we score it as 1. If there is inattention, then again we score it as 1. Disorientation, hallucinations or delusions or psychosis, psychomotor agitation or retardation, inappropriate speech and mode, sleep-wake cycle disturbances, and symptom fluctuation. So these are the 8 parameters that we need to see. And if the patient shows a positive response towards these parameters, then we score the patient, score 1 point for each of these parameters. And if the final score comes more than 3, then that means that delirium is present. So a few of the non-pharmacological approaches in delirium management would be rehabilitation, reorientation, cognitive stimulation, improving the sleep, improving wakefulness, and reducing hearing or visual impairment, which might also cause the patient to be delirious. Moving forward to the pharmacological approaches in delirium, the causes of delirium may be multifactorial, and identifying and correcting the underlying etiology is the first step in the management. The PADIS guidelines suggest using dexmed for the delirium in mechanically ventilated adults when agitation precludes weaning or extubation. Some of the other drugs that we used for patients in delirium would be haloperidol. The dose is 0.25 to 0.5 mg every 4th hourly or 0.5 to 1 mg every 6 hourly. The maximum dose would be 30 mg per day. Adverse effects are extrapyramidal symptoms, sedation, orthostatic hypotension, and precautions. Patients with dementia-related psychosis. We need to be cautious in patients with dementia-related psychosis, Parkinson's disease, and CNS depression. The next drug would be olanzapine. The dose is 5 to 10 mg every 12th hourly, and the maximum dose is again 30 mg per day. Adverse effects is drowsiness, extrapyramidal symptoms, neuromuscular weakness, serotonin syndrome, and high doses may cause cardiac arrhythmias, cardiopulmonary arrest, and extreme sedation to coma-like states. And precautions, again, we need to take with patients with dementia-related psychosis, risk for severe sedation. Qutipin, one of the most common drugs that we tend to see, 12.5 to 25 mg, and maximum dose is 150 mg per day. Adverse effects are sedation, orthostatic hypotension, extrapyramidal symptoms, QTC prolongation. Precautions to be taken with patients with dementia-related psychosis and risk of suicidal patients who have risk of suicidal thinking, and patients who have hypotension. Risperidone, 0.5 to 1 mg, and the maximum dose is 6 mg per day. Adverse effects would be cardiac arrhythmias, anticholinergic effects, and extrapyramidal symptoms. The precautions to be taken again with patients with dementia-related psychosis, cerebrovascular disease, and cardiac conduction. Ziprasidone, 20 mg oral, maximum 100 mg per day, and if we have to give it as IM, then 10 mg intramuscular, maximum 40 mg per day. Somnolence, extrapyramidal symptoms, dizziness, and orthostatic hypotension are some of the adverse effects. And patients with dementia-related psychosis, patients who had recent acute MI, seizures, or hypertension should be looked out for. Okay, so what is spontaneous? So far we have discussed about pain, agitation, and delirium. And now we'll go ahead with spontaneous awakening trial and spontaneous breathing trial. Spontaneous awakening trials are the stopping of narcotics as long as pain is controlled and sedatives every day. And if required, then we have to restart either the narcotic or sedatives at half of the previous dose and titrating as needed. Spontaneous breathing trial determines the readiness for liberation from mechanical ventilation by allowing a patient who meets the predetermined criteria to breathe spontaneously, independent of the significant ventilator assistance. Okay, so let's look at how do we see if the patient can be weaned off their narcotics or their sedatives, and following by how can the patient be weaned off from their ventilation. Starting with the daily awakening trials, we need to assess for daily awakening of the patient. First of all, the exclusions for this would be increased intracranial pressures. The normal values for the intracranial pressures are 7 to 15 mmHg. Neuromuscular blockade, significant ventilation support required, such as very high PEEP or FiO2, CABG immediate post-op if the patient has undergone coronary artery bypass grafting, then immediately post-operatively we cannot awaken the patient, and any other site-specific exclusionary criteria. Once we perform the daily awakening, we wean or stop the sedation and consider decreasing narcotics infusion by 25 to 50%. Then we assess if the patient is awake and calm. We need to use our sedation scale, that is the RASS scale. And if the RASS score is between 0 to -1, then we can proceed with the SBT, that is the spontaneous breathing trial. That means that we can go ahead with weaning of the ventilation. We can go ahead with trying to weaning of the ventilation. But if the RASS score does not come from 0 to -1, then we need to restart the sedation at half of the previous dose. But if we are moving ahead with if we are moving ahead with the spontaneous breathing trial, then we need to assess for the SBT first. That should meet all the criteria to proceed. That is, the patient should be calm and cooperative. That is, the RASS score should be 0 to -1. The patient should be hemodynamically stable. The PEEP should be less than 8. The FiO2 should be less than 0.60. pH should be greater than 7.34 and SpO2 should be greater than 90%. If the patient does not meet this criteria, then we cannot proceed with the SBT. But if the patient meets the criteria, then we can proceed with conducting the SBT for 1 minute. The mode of the ventilator should be kept on CPAP. The PEEP should be 0. Pressure support ventilation at least 5 to 10 and FiO2 should be unchanged. After 1 minute, we need to calculate the rapid shallow breathing index. And how to calculate is that respiratory rate by tidal volume in liters. If it is less than 105, then 80% success. And if it is greater than 105, then there's a 95% of failure. If the patient does not meet this, then we need to return to the previous ventilator setting. If the patient fails to achieve this, then we return to the previous ventilator settings. But if the patient has a success, then we conduct the SBT for up to 2 hours and there is continuous monitoring or continuous reassessment. During the reassessment, again, we see if the respiration rate is greater than 35 per minute for more than 5 minutes, if the SpO2 is less than 90% for 2 minutes, if the heart rate change is 20% from the baseline and the blood pressure change is 20% from the baseline, if there is accessory muscle use, and if there is increased anxiety, then then we need to terminate the SBT and we need to return the patients to their previous ventilator settings and then rescreen the patients in 24 hours. But if the patient, if the SBT is successful for 2 hours, then the patient has successful completion of the SBT, and based upon the discussion of the ABG and based upon the discussion of ABG, the extubation can be planned with the ICU consultants or the physician. So this is how we do the spontaneous awakening trials and the spontaneous breathing trials in order to wean off the narcotics or sedatives on a daily basis, and in order to wean off the mechanical ventilation for the patient as well. So let's see some of the case-based scenarios. TO is an 81-year-old female admitted for respiratory insufficiency following a virus. At this time, she is on NIV, but is showing signs of intermittent agitation, and you are worried she will not keep her CPAP mask on. Which of the following is the most appropriate for TO at this time? Okay, so the answer would be, let's see the probabilities first. Administer lorazepam 1 mg every second hourly. Assess the patient for pain and treat if necessary. Contact the consultant to consider intubation, or contact the consultant for restraint orders. Lorazepam, as we have seen, that it is a benzodiazepine and which can be a risk factor for the development of delirium. So we would like to avoid lorazepam. There are no indications for intubation for the patient right now. So we would not be going ahead with intubation, and we would not restrain the patients as well, because patients who are on CPAP, it is it might be difficult for them if they pull off their CPAP mask during critical situations. So the answer would be assess the patient for pain and treat if necessary. Next, TO, who is the same 81-year-old female who remains CAM ICU positive, that is delirious, is becoming more agitated with hyperactive delirium. The family has informed the staff that patient is prone to sundowning and has mild dementia. Reorientation and family support is not relieving her distress. What medication would be appropriate to reduce the risk of patient and staff harm? Lorazepam 1 mg every second hourly PRN, fentanyl 12.5 mcg every second hourly PRN, haloperidol 5 mg every fourth hourly PRN, or melatonin 5 mg every nighttime or bedtime. So here again, lorazepam, as we have seen, is a benzodiazepine, which is a risk factor for the delirium, whereas which cannot be given for this patient because this patient is already in an hyperactive delirium state. Fentanyl, which is an analgesic or an opioid analgesic, there is no indication for pain, or there is no assessment of pain currently in this situation. And melatonin, there is still discussion upon the use of melatonin in ICU. So the answer would be haloperidol 5 mg every fourth hourly PRL. And the last case would be GD, a 59-year-old man who, with no significant medical history, is admitted to the neurosurgery ICU after a subarachnoid hemorrhage and needs intubation. He is hemodynamically stable. However, ICPs have ranged from 25 to 30 mmHg, whereas the normal is 7 to 15 mmHg. Sedatives include a fentanyl drip and a propofol 30 microgram per kg per minute. His sedation score is deeply sedated, and the intensivist asked about doing the SAT, that is the spontaneous awakening trial. Which clinical value would exclude this patient from undergoing the SAT? Patient needs ongoing pain medication. Patient is younger than 60 years. Propofol needs no SAT because it is a short-acting agent. Patient has an ICP greater than 20 mmHg. So the answer to this would be patient has an ICP greater than 20 mmHg because as we have mentioned, there are some exclusion criteria that we need to look out for before going ahead with the spontaneous awakening trial, of which one of those is increased intracranial pressure issues. If the patient has elevated ICP, then we cannot move ahead. We cannot move ahead with the patient we cannot move the patient ahead for the spontaneous awakening trial. Thank you, and I'm open to any questions.
Yeah, thank you, Dr. Sophia. It was an amazing presentation. And regarding this remifentanil is a new class of opioid, right? So this
Yes.
is clinical trial right now. The ongoing clinical trials are conducted in all over the hospital life, I suppose.
Yes, that's right.
And your presentation on this confusion assessment method and other assessment methods were very much new to me, and hope all the listeners would have been educated on about this. And yeah,
Thank you so much.
so we'll end up the session. So session was so brief and informative in the management of pain, agitation, and delirium in critical care. And thank you, Dr. Sophia, and thank you, everyone. So stay tuned for further update from FCPI. Thank you.
Thank you, Dr. Vishpa.